All right, we are going to continue eating, but we're going to go ahead and continue with case presentations. So, obviously, the interesting cases are the disasters, as you know. So we are going to go ahead and present the case and kind of talk about what people would, what different people might do in this situation. But we'll go ahead. Josie Hein is my physician's assistant, and she's going to go through the case. And I will kind of ask the audience as we go along how you would treat the various complexities that arise or complications that arise from this particular case. Thank you.
Good evening, everyone. I just want to say it's a pleasure to be here in Kenya, a beautiful country, and where everyone welcomes you with warm smiles. So let me get started with this case. This is a 32-year-old female who came to Grant Medical Center April 2018. She had 2 months of posterior cervical pain and pertinent medical history. She is an IV drug user. She last used 2 days before she presented, and she came in with a subjective fever, some diffuse paresthesias to her upper and lower extremities. Objective exam, she had some tricep weakness, 4 out of 5, and some decreased sensation to the back of her right hand, of 19.
So, if you go back to the exam, the clinical scenario will guide how aggressive you are. So, subjective fevers, paresthesias, and basically the triceps is weak. And that's about it.
MRSA bacteremia.
So, in the neurologically intact patient, right into an operation.
Do you have any axial? Do you have any axial images of the
I don't have the actual images for this presentation, but I can tell you that on the actual cuts, there's severe stenosis at C56 down to 71. So anyone else as far as,
Excuse me.
Yes.
Do you know what the HIV status was of this patient? To portion any AIDS medications?
No.
Just to go along with what Alex said, so, from afar, the CAT scan, the first thing the ER gets, the focal kyphosis, something growing there. You can see the epidural of it, CAT scan as well. So it's 5, 6, 6, 7. 6, 7, this looks like the one with the posterior discitis, or discitis causing a ventral epidural abscess. I agree with Dr. Galler for that exam. I would be hesitant to operate right away. I would do antibiotics for about 6 to 8 weeks till it became, essentially sterilized. And at that point, I would operate because that's why you have a stable fracture. And that disc is not, it may fuse across, but that deformity will be there after it fuses, and that will cause ASD essentially long term. So from a global alignment standpoint, I get some soy film, I make some baseline measurements, SBA, cover mismatch, and then I would probably go ahead and correct the curve. I do a 2-3 level ACDF, and down the road after the completion. Now, however, let's pretend that the exam was worse than that. The patient was progressing to paraplegia. That could be from a couple of things. One would be expanding abscess. Two would be a venous thrombosis, as we all know, which we can't do anything about. But we can take away the pending factor causing the venous thrombosis. If I were to fix this, I would use allograft opposed to anything metallic or PEEK, because PEEK has a tendency to hold on to germs, as we all know. The allograft will integrate with the bones really purely, and you just kind of pray at that point that it would just touch them until after you wash it out. But that would be a protein restriction.
I'd like to play devil's advocate. Right now, the consensus is maybe treat this medically, but with severe stenosis, already a deformity, with epidural abscess and the beginnings of a neurologic change in paresthesia, my recommendation would be surgery up front. People decline neurologically rapidly with osteomyelitis, discitis, and epidural abscess because they have a venous thromboembolism more often than an increased stenosis. And so you can only treat venous thromboembolism by preventing it. Once it occurs, an infarct in the cord is irreversible, even if you decompress the spine. And so in these cases, I tend to be more aggressive, and the literature does support instrumentation at the time of decompression. And so there's a concern always about instrumenting the spine in the face of infection, but it has been shown to be quite safe. And the benefit of removing the epidural abscess outweighs the risk of chronic infection with instrumentation. I would agree that something other than PEEK is useful, so even autograft in these cases is more useful, but metallic instrumentation is widely acceptable in these cases.
Dr. Rory, or let's get a different perspective. Dr. Wooten, how in Germany, give us a different perspective. How would you approach this typically at your hospital in Germany?
Well, I mean, just like Dr. Hara said, with this, the feeling is always like when you have this severe stenosis and you already have some, even if it's a slight neurologic deficit, if it gets worse, you're basically running after it. Yeah. So I would also tend to be much more aggressive here, because I mean, if somebody had a degenerative stenosis, and we saw some signals, some neuropathic signals in the spinal cord, we're typically, in Germany we're more aggressive on that. So I'll probably be aggressive. I'll take off that will be 7 and do a ham scale and with a plate in front. That's the way I think that's the tendency we have.
Okay, great. And I want to get the perspective from in Nairobi, something like this shows up. First of all, we have a lot of problems with IV drug users. I know in our hospital, we're dealing with this kind of stuff every week. Every week, we have someone who's an IV drug user who's myelopathic or who has radiculopathy or back pain from an epidural abscess of some sort, osteodiscitis. Is this a problem in Kenya, and how do you approach this here?
Thank you, David. I think in my hands, we tend not to have a lot of IV drug abusers. HIV is more prevalent, so that would be the cause for it, not necessarily an IV drug. 1. 2, I get twitched with somebody's going to epidural abscess from that narrow space, and with a potential to deteriorate. I have been caught like that before, and it's like also a little voice shy, so I tend to be more aggressive. And I always get amazed when you get into that epidural space how that pus shoots out. It's under so much pressure. Give them extra incision on the head to get a piece of bone. What I've found quite useful is back dressing. So you actually have not only that, once you decompress it, you have a vacuum dressing as well. So you're going to be getting the antibiotics in that as well. So from my point of view, I would be more aggressive. Because
as far as aggressive, sorry to interrupt, would you do discectomy and instrumentation, Or will you do, and what exactly would you do?
I just put a graft.
This is a graft, okay. A graft, autograft, allograft?
Autograft.
Autograft without any type of instrumentation.
Can it's fixed like with the goods with the I know it's in a moment. Yeah. The name will come this time. This is autograft.
Thank you.
So the question for Dr. Blum is, which level will you do?
I know we're limited without the actual, but I can take my word for it. You have stenosis from here to here.
The stenosis actually getting higher up. The disc itself at 2, 4,
5, 6,
6, 7. 5, 6 is not the disc. 6, 7 as well. So the 6, 7 from that's a T-weighted image would be more liquid. So once you get the disc out, and the pressure itself will get it level. So I guess a single level.
Single level discectomy, no fusion with autograft, no instrumentation. Now, are there any other? Let me get a show of hands for all the neurosurgeons or orthopedic spine surgeons in the room. Could I get a show of hands? Okay, Uganda. How would we approach this in your facility typically, or how would you approach this in at your hospital? Just whenever I ask a question, please stand up, say your name, and then answer the question. Thank you.
Once again, Hussein Zainudin from Kampala. There are key catching segments with this patient, especially the neurological findings of this patient. So we see that there's a fallout, especially in the motor aspect, and of course there's a bit of sensory aspect. When we look at that, as some of the discussants have put it forward, we don't have a lot of space within that canal. So when you have that infection, urine, what you have to do is to decompress that patient as quickly as possible, because chances of fast deterioration are very fast. This is an infection. It is not a tumor that you can give it time and then try to do more. And this is an infection. The earlier you take the patient to theater and decompress, I think I will also fall into an opinion of Rumia. I'd rather take the iliac crest, probably no instrumentation. But these are schools of thought. Anyone can give an opinion about.
What level? Would you do the one level or both levels? Because Dr. Wilson mentioned he's going for where the pus is.
I think I'll also do probably one level.
One level
for this patient.
Great. Okay. Next slide.
So we took her for a C5 to 7 ACDF, a partial hemicorpectomy to take out the abscess, and intraop culture showed MRSA. Her post-op exam was stable. These are our post-op uprights.
So post-op x-rays look good, and then go ahead.
So she came back 2 months later with some neck swelling and quadriparesis. Upper extremities were 3s and 2s, and then her lower extremities were hip flexion 2, knee extension 3, plantar flexion 2, dorsiflexion 0 with some hyperreflexivity. What would you do here?
So she's patient is myopathic, really weak at this point. Go ahead, next slide.
So there's an MRI with an abscess anteriorly.
Your MRI shows you this. So anybody, any of the, anyone else? Let me see the hands of the neurosurgeons again. I have to put it in my long-term memory. Back here, were there any more? Okay. I'll put you on the spot again. Over here. What's your thought process? How would you approach this? What are you thinking? And tell us your name and where you're from.
Yeah, my name is Nahali from University of Nairobi. Why does this is after how many months?
2.
2 months. 2 months or so. So this is a reconnection around that area. At the MRI. Yeah.
Yes.
That's causing Stevens. So this patient is
So what are you going to do as far as the procedure of choice? What do you do?
I'll call my boss.
So you make the phone call to your boss. Your boss, I'll assume I'm your boss right now, because if my resident calls me and says, I don't know what you want to do, I say, what do you want to do? You're going to be in this spot very soon. What do you want to do? What's your plan? I actually don't allow them to call me until they come up with a plan. So what's your plan? And you don't. It doesn't have to be right. And we're just discussing. So just give me. You're on the right path. You're telling me this patient needs to go back. Patient's weak. You have compression. You have hardware in there. What do you do?
So the implants need to come out. Somehow we need to stabilize this spine posterior and anterior. That part needs to come out.
Okay, so what's your procedure? What are you booking for your surgery? What are you telling them that you're going to do?
We're going to do 7 level connecting from C5 to 7 and put a long cable and probably stabilize posterior as well.
Okay, so he's going to do a corpectomy and stabilize posteriorly. He's going to take all the hardware out, do a corpectomy, evacuate the abscess, and then stabilize anterior and posterior, instrument, everything. Now, what's your corpectomy cage of choice?
You need a long one.
Are you using metal? Are you using autograft? What do you think? What do you want? Okay. All right. Great. So that's one approach. Now, would anyone approach this any different? Anybody? Dr. Patel.
I might need a microphone sometimes.
Give him the mic.
So, can we go back one slide to me a close-up film real quick?
Tell us your name and where you're from.
Sorry. Dr. Patel from Boston, Massachusetts. So, back to my original point. So now if I hear this on call, next slide over, with the patient has new ventral abscess, spanning multiple levels. And there's also that abscess pushing the trachea and esophagus anterior, so this patient has some breathing or swallowing problems. So obviously you have to go from the front to take out that abscess up front. And the nice of the infection is probably the foreign bodies that are now infected in the antibiotics not getting to. So I would remove all the metallic hardware. I would do a multiple level corpectomy, including a fibular strut, or a strut in with a plate across that. Now, a few companies do make plates for the struts. I think if you have one, and I think Globus has the next one too. We're actually integrated right to the strut, top and bottom. So you can put multiple screws in there. The screws at the top, screws at the bottom. Put it in, and put it that way. That way, the oxygen integration would be greater than this. It's only 2 months of obviously having to see fusion, especially in a setting of infection. But that would be the greatest chance to fuse, I believe, at that point. And then again, just compliance, right?
So you're doing everything up front, not any support from the back, or are you supplementing?
Yeah, so I would do a 360 rotation. Correct. So I think the most important thing up front is to decompress that abscess in the neck. The swelling in the neck. It's only a matter of time for their airway issues. I think this is an emergency. It's supposed to the night comes in. So you can wait until the morning. You remove all the hardware and then do a strut. And then I would flip the patient and do posterior spinal mass stabilization. And then
I would try to get this person to a rehab for at least a few weeks, so it guarantees me that the patient being antibiotics and they're compliant. I am forcing compliance on the patient at that point. I won't be surprised how much patients will, but if they, you know, the VNA shows up, knocks on the door, then I'm home. You know, things like that. You know.
Okay, so we have two options right now. We said similar plan. The end result seems very similar, except that you are using titanium and he's using a fibula strut graft. Any other thoughts from anyone else as to how to approach this that's different from the two? Oh, you have a question, Dr. Das?
It's a medical question, but I'm just a medical oncologist among the surgeons, neurosurgeons. The cause of the infection was something unusual, but what the infection is concerned have to say.
MRSA, MRSA. It was MRSA, bacteremia.
Anyone else with a different plan?
I would say different. I would say a supplement.
Supplement plan.
So what I've been doing now for these big infections is getting autograft or trying to minimize foreign material. And then I took a cue from the orthopedic guys, and I've been using antibiotic impregnated beads. And I packed the graft with that. And you can fill it with vancomycin. And so basically you have a vancomycin infused graft. So I've been doing that for osteodiscitis and osteomyelitis. So type of graft you use, you're using expandable gauge, whatever. It's kind of hard to pack those. I go old school and use like a harms gauge. You cut it, put under traction. You really pack that thing with a ton of autograft, and then you mix it with antibiotic beads. And I've been fiddling with that, and it seems to have been reasonably helpful recently.
Thank you.
No data though.
Thank you.
Just to add on from what Robert said, the delusion here. The other graft, as opposed to a strut graft, fibula, you have to use grip. You've got a nice curve, and in terms of actually using traction, bead testing, and what I said about the vacuum dressing, it has saved my bacon on more than one occasion. And it's actually quite spectacular because it just keeps sucking it away. And we've got portable vacs now. There's a chap who actually provides this in the trade, and he actually does it around the country for me. So I've had patients in Kisumu who had wounds, and they've been vacuum dressing, but most recently I had an epidural abscess. This was thoracic, and we had to go in twice. No instrumentation, just from disguises. And the vacuum dressing actually helps. So not only a strut, but also use a vacuum dressing.
Thank you. Next slide, please.
So she went that day for a C5 to T1 cage placement with a vertebrectomy from C6 to 7 and evacuation of the abscess. Then the next day we took her for a posterior backup from C4 to T2 and laminectomies at C5 to T1 and intraop cultures grew MRSA. Post-op day 2 she had some improved strength, and then by post-op day 4 she was full strength. These are also her post-op x-rays.
I will not clap yet. The disaster is a real.
He's presenting this.
So far. Both sides. Yeah. Well, so at this point, strength's improved. Looks like the dust is settled. Sunny skies. But the weather changes. Next slide.
3 months later, she came in after a fall 3 days ago, and she had this lump in her neck.
Lump. So
This passes the squint test, right?
the squint from the back. All right, you can see from the back. So, this is when the weatherman says, hold, go to the basement. We have basements in the USA. Tornado warning, hold on to something. Everybody clear the streets. The storm is coming. It is here. This is Katrina in neurosurgical terms. So, anyways, what is her exam?
Oh, what is the patient's
She was intact.
Patient is intact.
Laminectomy safe.
Okay? So, Dr. Lobel. You are a storm chaser. How would you fix it?
Can you back up to
I can
the
show her the CT.
films before?
Yeah, and I can give you.
Now-
Let me give you a little more too. I can give you a little more than the X-ray.
I also know Grant is such a wonderful place and safe and secure for these patients. But when you've got soft bone from an osteomyelitis, the question is, how far should you actually go north? Is this something that you go up to C1, C2, because you're going to get stronger fixation? You already have somebody who's going to reinfect anyways. The IV drug user, if they don't already go back to IV drugs, is still going to infect themselves. So looking at this and then going to where the failure is, even though she's fully intact, and I'm sure you got an MRI scan, which shows some kinking of the spinal cord, I'd probably put her in, consider some Gardner-Wells tongs, get her straight, get her reduced, and then I'd more than likely going to have to consider redoing her anterior, posteriorly, whether or not you go up to the occiput, or knowing that she's 31 years old, go from C1 all the way down to T3. And then you have to look at your screw lengths also. So, unfortunately, storm chasing I enjoy too, but let's see what you did.
So what do you say you'll do?
I either get all the way up to the occiput after reducing in some tongs.
No, okay, go back.
Here.
So here, do you have another slide?
There's a CT.
There's a CT scan. Okay, so that's what the CT scan looks like.
She's pulled out already, but you need to reduce her. You can also get a CT angiogram on that too worry. But you need to reduce her to stop this chin up chest deformity.
So, are you taking the hardware out? Are you just putting the patient in traction?
I'm going to transiently put her in traction, get her reduced.
Okay.
She's, of course, admitted for this.
Okay.
And then you're going to end up doing front back, and you're going to take out your anterior work, you're going to have to do your posterior work.
Now,
you should be able to preserve your lower screws, so you don't have to worry about that again.
Now you're taking your anterior work. What are you doing with it?
I am hoping that you'll show.
I'm not showing up. I'm running.
Oh yeah, you're back. You're
I'm in Kenya.
He's
I'm in Kisumu.
And yeah, of course. You know, you don't have a lot, unfortunately, to work with because of the superior aspect of where you've got your corpectomy cage. But I think the problem is actually distal. So I think she's kinking over C3, 4, 5. I think you've got some bone at 5, and her kinking is actually at C4 and 5. So you're going to have to reduce her and pull her back up there. You're probably going to have to extend your corpectomy anteriorly. Use the bone that you've got with the assumption that there's no active infection, and then flip her back over and extend your posterior instrumentation and have longer screw fixation.
Are you still going with titanium up front? Are you? What's your gauge of
My
preference
gauge my
in this
gauge of
situation?
preference, you can probably just do a strut, maybe a scratch or something. The rib idea I like. I haven't thought about using rib, but you know, I don't think you're going to get enough support from the rib, but if you morselize it, I think it's going to be a better anterior fixation. So fibular strut, maybe surround with some rib and some hip graft, and then you're going to do a long posterior fixation. You can even consider.
And you're going to the occiput, right?
I would think about going to the occiput, but she's only 32 years old. But you may have no other option. But I like C1, C2 fixation.
Okay.
Nice long screws.
Thank you. Go ahead.
Look at C2 though, the frame is right there. So getting the screw into C2 might be rough. If you look, we don't have the axials, but you can see the frame and vertebral frame and right to C2. So that might be one less point of fixation. So you have to take all that into consideration when you're determining how high you go.
I think you can still get a screw into C2. I mean, it's just that on this axle cut,
Yeah.
so you have a fat cut, but you can get a screw.
So a point for the residents though is you must always get a thin cut CAT scan through that area before you do bar screws or screws in that area, because the vertebral artery can sneak into the path of that screw, and you don't want to identify it by its contents.
Absolutely.
Well, what I was going to ask was, with all this soft bone and infection, you're putting more instrumentation, pull out, it's pulling out. Would you think about putting something extended, like a halo S?
Okay, so are you so at this point you're
No, after the reduction, as you said.
okay?
Yeah.
So after the reduction and fixation, or you're just reducing and putting in the halo?
No, you take out whatever hard is there solving the problem. You put more, your structure out, but as opposed to using the fixation on the screw itself, you put in a halo.
A halo, so full stop and then halo after only anterior fixation.
No, because the posterior one you have to take out as well.
But are you putting back any posterior fixation, or are you leaving the posterior out?
You won't be able to get proper access of that. So, with the same way you put the graft in front, you already rely on the halo. So once you take the screws out, and you on the graft, well, that will work, because I'm being ultra conservative here from that point of view, because the way they are put out there, I've got a feeling that even if you go out to the oxygen, whether that will keep pulling up, I am not sure. So I would start graft, instruments out, halo. I mean, the old days people would be used to be in bed for six months. I think if you do that, well, you get fever and die. So get an ambulatory with a halo after you take out the instrument. So as opposed to putting hardware, start graft, only graft at the back, start out, and halo.
Anyone else?
So my name again is Timothy Okutu. I'm just trying to understand, I mean, the ventral cage. I mean, for us guys, naturally, such a cage will come with a plate, a ventral plate. So what was the reason behind, or is there a reason why there was no ventral cage placed?
I have no idea. I'm not sure.
Yeah.
So I can't answer that question. But so now this is what you have.
Okay.
How are you going to deal with it?
Yeah.
Your resident calls you and says, "It doesn't look good."
It's difficult. I mean, I would try and get some electrodiagnostics and try and reduce it and carefully reduce it, remove the hardware, all of it, from probably not the screws, just maybe the last thoracic screws I'll leave them in, the ones in T1 and T2.
Okay.
Yeah, I'll leave them in.
And then you're taking everything else out.
I'll take everything else out because everything else is outside space. Yeah, the rest of the screws. Then we'll try and reduce it. I think with this age, going through the occiput, I have my problem with that. So I'll probably take it up to C1, C2, and try and put a longer, maybe a arm's gauge, fill it up with bone, and then try and plate it from ventral, and then have the patient like a neck brace for some time, and just and just regularly controlled. Then
Did you say you were replacing the cage up front?
the bone cage, I'll remove it.
You're removing it?
Because the bone, the C5,
Yes.
3, 4, 5, yeah. I mean, I think that bone is disturbed because it has to come off the bone. I'll remove that, and I'll put a longer cage up to just up to C5. Remove the C5 below C4.
Titanium?
And a longer cage.
Anyone else? That's something different. Anybody else do something different? Okay, next slide.
There's an MRI too.
So that's the MRI. Sorry, I didn't show you that, but go on, next slide.
So she went for an occiput sheet 3 posterior fusion and halo placement post-op.
So realign halo put in place. Now, go ahead. Hold on. Go back to the slide. Anybody? Any thoughts?
So again, there's no plate over the cage, and the cage is into a partially corpectomized C5. All right? So that's going to fail. What I probably would have done was just take the rest of 5, get it to 4 with a fresh end plate. If you're lucky and that thing will expand and get there, probably could have gotten. That ain't gonna work.
Next slide.
So 5 days later, she had some posterior incisional drainage.
She's still in the hospital.
She's still in the
She hasn't
hospital.
gone anywhere.
She went for a wound drainage and wound mass placement.
And then this another scan post that initial. This is just go ahead. This is just a little bit. The patient's still in the hospital. Any thoughts? Any thoughts? So that's what else.
With a fibular graft from C4 to T1 and upper x-rays.
So, what's their exam this one?
She was attacked.
So vision's intact. Fibular graft is in there. You got your plate. You got your posterior fixation.
You got the halo.
You got your halo.
And she wants to have, she suffered because it's hot and stuffy.
Everything looks great. Next
All right. 6 months later, she had some drainage for a month and some neck pain for 4 days. So we got a CT scan.
So then this happens.
She was dehiscing, and her CT obviously showed hardware failure.
I'm going to
Show
show
she was admitted.
This is actually a vertebral body over here. That's not what it is. You can appreciate it with all the without scrolling through. This screw was in here and just kind of pulled this all out, and this screw is sitting now. And this is another the body below, but this screw belongs over here. Okay. So now chin on chest.
So
She's still doing drugs?
yes.
Yes.
And Pipline?
Does she have a Pipline?
And does she have a vegetation?
Yes.
That makes it really
Yes.
She has a vegetation. Why is she seeking just because of the drugs?
Well, at this point, the MRI, do you have an MRI?
Yes. No, we don't.
Oh,
Because
so,
that night she got weak.
I mean, this just fell apart, and she was,
Yeah, what's up?
she was lost to follow-up, I believe. And then halo,
She didn't come back for a follow-up.
she already took her halo off at home. So then you have this. You're on call, and your favorite resident calls you and tells you, things don't look good. What do you do? That night, the patient gets, you can't get an MRI because she can't tolerate it. And she gets weak significantly. What is the example now? You have the.
So that night she was a right hip flexion 1, knee extension 2, and then distally dorsiflexion was 4-, plantar flexion 5, and AHL 4-.
So you have a patient that's getting weak significantly compared to when she came in. So, anybody? What do you do at this point?
So you take it back, you take your posterior rod out, you leave your instrumentation superiorly, you remove those 2 screws that, the T1, T2. You take the T1, T2 screws out, you wash it out, you send the T1 to T6. You put it in your eye.
And one of the things I wish we had is you don't appreciate it as much, but you don't see that well in this view. But the rest of this vertebral body is pushed back into the canal.
Does she have scoliosis films? Ever?
Has she had scoliosis films?
Just curious with her.
Did she have scoliosis films up to
At
this
that point,
Oh, before.
I don't think she had any at that point.
And also DEXA scan, too, what thinking aloud here. She's failing, because she's pulling out, right? The bone part is horrible. Maybe she has some sort of strange, early onset osteoporosis on top of her, she's confused. Something we're missing here, why is she pulling out?
I mean, I think it's because she's that you have a long construct and it's
And then she has like no curves. The first time, she reversed lordosis on the first initial scan, which kind of scared me. Now, I don't see any curves, and that's a short segment X-ray, so I can't tell from the international.
so, well, now the problem is she's weak. So yeah, what are you going to do?
I would go down T6.
Go down to T6?
I mean, always the question is how far down you go, right? At this point, just like when you're going from T10 pelvis, you go to, T4, oxford, your stem to sternum, say it real quick. I would go T6 and then, wait for it to come back in and 8 weeks later, get something else.
Anyone else?
I would agree, except that I may go longer, because we've already had somebody fail several times, and if you end your construct at the apex, you may find yourself in the same position. And so I would go to even T10, T11, past the thoracic head.
So everyone says big construct. Go ahead, next slide.
Okay.
I guess that's the question.
I've got a one of choose question. Who is funding all this?
Taxpayer.
Dr. Garrison,
Right. Okay. Well, if this was in our environment, it would have been sorted out some kind of, because the funding basket would not have been enough for the surgeries to be done, and some other issue might have cropped up. And this is the length of time when she first presented. How many months is this now?
This has been 11 months.
Yeah.
So in a year has had multiple surgeries.
In hospital stay.
In hospital multiple times.
Antibiotics, implants.
Leaves, gets lost, or shows up in the disaster.
That's my question. Okay, fine.
Next slide.
So she went for an occiput T3 hardware failure removal, sorry.
Oh, go back to the previous slide. All these screws up here and the occipital, but you can't actually appreciate here, but all these screws here have all pulled out. What's a bone density? Do you have bone density at this point?
No.
No.
So occiput to T3 removal. We did laminectomies at T2 to 4 with rhizotomies at T3 and 4, and then T3-4 corpectomies and a posterior fusion from C1 to T8. Postoperatively, she was still weak. Uppers were intact, but her lowers had a 1 out of 5 left hip flexion and knee extension, and she had progressed to zeros throughout the hours when we were getting the MRI before surgery. Within the next few days, she improved to an Asia C, and on the 10th, Asia C.
So at some point here, this cage is slipping out a little bit. So she goes back to surgery, gets the rods out and the cage repositioned. Okay? So now, that's what you
Going to
have.
be placed in a halo again.
And she's in a halo again. So, go ahead.
And this time we did get some scolies.
She has scoli images.
So still some kyphosis.
Alignment's not bad. Alignment's not bad at all.
For now.
For now.
Okay.
Go ahead.
So then a week later, she had another posterior wound drainage and dehiscence. Went for another IND and wound vac placement.
Plastics gets involved, they do some kind of wound closure.
Yep.
Go ahead, next slide.
Then a month later, she came to clinic for follow-up with some films.
Anybody, any thoughts? What's going on?
Where's the halo?
Took it off.
I think on this one, plastics. And heal anymore. And you have this. With that? Actually, no. This is just a bad image. The thoracic cage is fine. You can see that the thoracic cage is actually fine.
Now, what's the neurology?
What's that? Oh, she was.
She's intact.
Yeah, she was intact.
Next slide. So, on this slide, the lateral pedicle fracture at the bottom of the construct. Okay? This is the top of this pedicle. This over here. Okay? This is the bottom of this pedicle. And the bottom screw in this ring washer just split the pedicle and the lateral pedicle is fractured. Any thoughts? Pedicle? Dr. Rory?
Add more screws.
Add more screws. Okay, where are you going to? T11. Okay. Anyone else?
In terms of the, I keep asking that question. Because I mean, each of the schools that they put in, they pull out. So, is there any other method? I don't know. Is there
Let's say that the bone density isn't that great. What will you do different? Let's say alternate the screws. There we go. What else? Now, this screw didn't pull out. I think it just cracked.
That's part of the same issue, the same bones. So.
Yeah. Because as you can see this just kind of split the, I think it's just too much force. And it just kind of fractured that pedicle. Dr. Copeland? Any thoughts?
With all due respect, I lost interest in this case a long time ago. No, I agree. You got to extend your construct. I mean, yeah, and you know, certainly nowhere around here is the resource available, but you can consider. Somebody help me! I've been out of the U.S. too long. Not that I'm not Nepomuk related.
Yeah, just got a minute.
Well, no, but I'm not even that. BMP. Yeah, but you know, in our setting around here, we don't have any of that, and so I think you just got to extend your construct. Maybe to L2.
I think the problem is not the bondings. The problem is what do you call it? Adjusted level failure. And then we can see. Yeah.
So pretty much everyone's saying extend the construct. Dr. LaBelle, anything you do different?
You know, if you've already got some fusions, she's asymptomatic. If you already have fusion masses, she's asymptomatic. She still comes back with infections. You're going to just go all the way to the sacrum, just where pelvic screws in. But my thought is, it's going to go there. But why not pull out all your posterior instrumentation and just give her a holiday for a while? Let everything settle down. Let her wounds heal. If you need to put her in a halo because you've got some, you know, positive sagittal balance, then just put her in a halo. But at this point, my feeling is you've got a situation which is out of control. You're going to keep instrumenting her. The wound's going to break down. She's going to die. So pull everything out posteriorly. Let everything heal up. See what she does.
Okay.
And if she stays clinically intact and she's got a positive sagittal balance and she doesn't collapse any further, then so be it. Are we treating beautiful x-rays or a clinical exam?
She went for a T6 to T11 posterior fusion, just extended the breaths.
So hardware was extended, and next slide.
Some skull films.
Some skull x-rays, the alignment looks pretty good. What else?
We don't know yet.
And she's gone for now.
So next year's conference.
So next year's conference. I think that's it.
So in terms of question, in terms of support, let's say lost follow-up, do you have a system for surveillance where you can go and check on them? You use some terms, right? Something like home visit or something, check that they're home.
Home health.
You've got that.
Yes.
Yes.
For some of this, they just delinquent, they remove their base or board, or what happens?
A lot of these people, when with home health, usually it's something you have to set up when someone's in the hospital, or typically these patients have surgery, it gets set up, you go to rehab, then they leave from the rehab facility a lot of times with home health. But a lot of these patients, especially these IV drug users, even the home health people sometimes can't find them, or some people don't get approved for home health. It's various things depending on insurance. So it also depends on your insurance. So some of these people without insurance, it's kind of hard to get them approved for various things.
But she can get approval for this kind of instrumentation.
Which the thing is, a lot of times when these patients do come to the hospital in the United States, then it's almost as though in the U.S. you can walk into any hospital if you have something that meets surgical criteria. No one asks how much will it cost. I don't even know how much most of the procedures I do cost. I don't know if you guys do. But there are many surgeries that I do that, it's the transparency is not there. At least I find that it's a lot of times difficult to know the cost.
Just a little background on this. We have these patients commonly, now not to this extent, but osteomyelitis discitis from IV drug abuse. We had 70,000 deaths from overdose in the United States last year. That's more than our entire Vietnam War casualties over 10 years. That was 55,000 soldiers lost over 10 years. We lost 70,000 to overdose last year alone. So that's one problem you deal with. The cost for this patient is about $1 to $1.5 million. That's 100 million shillings for this one patient. How's the cost shared? Every person now in the United States, since 5 or 6 years ago, when we implemented something called the Affordable Care Act, or Obamacare, you may have heard of, now has at least some government insurance. Even without government insurance prior to that, 30% of our patients were charity, which means the hospital covered all their costs. Not necessarily the taxpayer. Some of it was subsidized from the government. The hospital covered the cost. So the hospital systems, even our nonprofit hospital system that we work for, is profitable enough to cover also the indigent care. Now everybody's insured. They have at least basic government insurance. The government insurance from our perspective is better from our perspective as a physician because I can order anything at any time. Whereas if they have commercial insurance, the insurance company may argue with us as to, right, you need pre-authorization. So the cost of healthcare is shared among many entities, but generally prior to Obamacare, the hospital covered most of the cost with some subsidies from the government. Since Obamacare, the majority of the cost is on the government healthcare system that's applied to all these patients that they qualify for it. So that nobody pre-Obamacare or post, like Dr. O'Rourke said, was ever turned away from a hospital. There are stories that, well, if you're too sick and you have insurance, you can't come. That's not true. Actually, they were much easier to care for because we could order any test and do any surgery we needed to. We didn't need any kind of authorization from a commercial insurance. So the cost is never an issue individually when we interact with the patient, but the cost over time to society is getting large, and so there is a big movement towards some kind of healthcare reform.
Thank you.
Thank you everyone for your participation.